Good morning.
Morning.
Get going in a moment. Okay, how do we get going then? Good morning. Hope everybody had a nice weekend. Thanks, Mo, for taking good care of our patients this week. Okay.
Good morning, Dr. Pass. Do you mind switching the view of the PowerPoint? It's the version right now where we can see the notes. It's
Oh,
like a
thank
small
you.
mini thing.
How do I do that? Does that work?
Yes.
That that fixed it? Okay. Good. Thank you. That's an amateur hour error. Sorry. Okay, so this is from the internet, and this is from a electrophysiologist who calls himself at EP Wave Doc, Andreas Musikbrot, who is asking, this is a 20-year-old asymptomatic male patient who has pre-excitation, wants to become an airline pilot. ERP of the accessory pathway is 250 milliseconds. Okay, so first question I would ask is, does the fact that the ERP is 250 mean anything in regards to risk? Why don't we ask Dr. Molly Marshall? So someone tells you the ERP is 250.
Good morning. I don't think so because my more threshold in the SAN of 250 is more, I guess, wait, are they saying
So what do we think about when we're saying like someone is at risk? But let's start from the beginning. What is the risk of WPW in terms of sudden cardiac death?
of risk of dying from rapidly conducted through the accessory pathway, so like from AFib and rapidly conducted?
Okay, and that's correct. And so what do we traditionally say is, shall we say, the line in the sand? What actually do we think represents quote unquote high risk?
We talk about the risk or how fast that pathway is able to conduct. Like the risk of if it's, for example, if it's a slower one, like above 300 milliseconds, excuse me, then the theoretical risk, although not fully proven, is that it can't conduct faster. And so thus, if you can't conduct that fast, then your risk of dying from a fast arrhythmia would be lower is the academic
That's
thought.
exactly right, and that's true. Cycle length 300 and longer would generally be viewed as probably to be low risk. What is high risk?
So high risk would be less than 250.
Right. So what do you make about and that's the rate at which at AFib the patient is documented to conduct. What do you think about them saying that the ERP is 250? Is that the same thing?
I don't think so.
That's right, it's not. So this doctor is sort of conflating ERP with shortest rat one-to-one. And they tend to be close to each other, but they are not exactly the same. And I do think it's true that if you had someone who had an ERP of 250, you would probably view that as at minimum not low risk. And I would agree with the general premise of his question, which is, I would ablate this. But formally speaking, it's not really the ERP. The ERP is part of the process. And as you so astutely pointed out, um, we don't really know what high risk is, particularly in kids, but this is a 20-year-old, so this would fall into the adult category as well. And so in adults, the shortest RR in AFib of less than 250 milliseconds would be considered high risk. ERP, not as clear, but bottom line is it's not low risk with that type of ERP. Okay. So first question is, as stated in the green letters, where is the accessory pathway located? And I will give you some assistance. And I would ask, since Molly, you started this one off, where do you think this pathway is? So why don't you take us through this algorithm?
So, for step one, you're looking at lead one and the the isoelectric or the positive negative nature of it. And so
We're looking at the polarity of the delta wave, remember?
Yes. So in lead one, for step one, it's saying it's negative or not
Isoelectric.
truly, yeah, isoelectric. I was gonna say not, but and so it's not that in lead one. And then the other part of that though is we want to make sure that the R to S is great, or like another criteria of that is if R to S is greater than 1, which looking at V1, I don't believe that's the case. So
Quite clearly, yes.
yeah, so very negative in V1. So then you go to step 2, which would be lead 2, and saying that it's negative. So that's not the case there either. It's positive. Then moving to step 3. So that's where we're finally striking here because V1 is negative or
Mhm.
yeah, it is.
So
And then
again, just for this for clarity, we're looking at this
yeah.
portion of the delta wave before it hits into the QRS. But yes, I agree with you. It's negative.
Yep. So then that's telling us, sorry if you hear my dog. That's telling us it's septal. And then moving
If
from
the dog has an idea, I'm happy to entertain it as well.
she has tons of ideas if you ask her.
Yeah.
So then moving from septal, we look at AVF. And so in AVF, the delta wave is positive. And so that's moving us down there. And then we want to see if the QRS axis is positive or negative. And so our QRS axis is going to be, we have a left axis deviation. And trying to see where most isoelectric. Okay, so it's like almost like a little bit of extreme axis almost. So I would call this then greater than that, so an anteroseptal pathway.
Okay. I mean, it's hard. I would agree with that analysis, but it's hard to say for sure because you could argue
Oh,
that
because that's all.
could argue this is
Yeah,
isoelectric too.
yeah,
If it's isoelectric, it puts it in the
left. Okay.
posterior septum. So the point is, for sure, this algorithm would suggest it's somewhere in the septal region, whether it's anterior. I don't think it's anterior because usually when it's anterior at AVF, you have a positive delta wave, as well as in lead 3, and these are negative. And remember, these are inferior leads, so sort of coming towards that area, if you want to think of it. Anyways, Dr. Musikbrot was nice enough to provide us with the ESI or the Abbott map. So this is just a nice example to show you this is the competitor to Carto, which we use here at Mount Sinai, but it's a similar system, electroanatomical mapping, and it also uses color coding in similar fashion. And what the doctor has done here, so first of all, this is the coronary sinus catheter. We're looking at LAO, so presumably the mouth of the coronary sinus is somewhere around here. This is where the tricuspid annulus would be. Mitral annulus would be somewhere around here. Whoops, sorry about that. Somewhere around here. What we see is that the red or the hotter colors seem to be congregating in this area, which would be sort of more posterior septal. So generally speaking, if you're sort of at the level of the mouth of the coronary sinus, or in this sort of, if you might think about the tricuspid valve as a clock face, posterior septum is like 4 o'clock to 5:30 or so, around this area here. Mid septum is like, 4 o'clock to about 2 o'clock, this area here. And this is where we think the AV node resides. And this is the bundle of His. So in this case, the operator, Dr. Musikbrot, has tagged where they recorded His signals. And this is a common thing that people do, is to notate where the His is, with the idea being, stay away from here. And this would be the anterior septum, which would be like from about 1 o'clock to about 11 o'clock on the clock face. So this would be probably, we would say this is posterior septal, and it's probably right posterior septal. So it shows you, the algorithm really didn't put it at the right posterior septal region. It put it in the posterior, probably in the posterior septum or mid-septal region, and that was right. But it's, you can understand how these algorithms are not going to be super accurate. They're not going to get you to exactly the right place. They're just basically putting you in a particular direction, which is useful and helpful when you're considering how you're going to map a pathway. And the two red dots are, just as in Carto, demonstrating where the catheter was at the time of RF delivery. And presumably what we're looking at on the bottom is the signals. And we see this is the distal ablation catheter. And well, no, actually, this is a reference catheter. The ablation is down here. So we have an A and a V, and we see that these are very tight. And again, it's very tight. And then all of a sudden, the A and the V interval get very long comparatively. Similarly, the reference, which is a coronary sinus pair, goes from being fairly tight to being fairly wide. So this is the point at which pre-excitation is lost. And we've talked in the past that when you're using standard temperature control radiofrequency energy, generally speaking, less than 2.2 seconds from the time you turn the RF current on is considered to be a good indicator that you are in the right place if the pathway were to go away in under that period of time. There aren't, to my knowledge, similar numbers or measurements about how long it takes to go away when you're using irrigated tip catheter, as Barry sometimes does. And the reason is because probably it depends to some degree on what power you choose. If you're using 20 watts or 30 watts or 40 watts, it can have an impact on the degree of, how quickly the pathway goes away or whether it goes away at all. And that decision about how many watts an operator wants to use is idiosyncratic and based on whatever the operator wants to do. As you know, I don't typically use that as my first line for ablation of pathways or SVT. And I think that it would be fair to say that most people today in pediatrics still do not use irrigation for this, but it's not that irrigation is wrong. It's perfectly reasonable. The other thing that we see here is that the operator, that they've recorded 9 grams of force when they were touching the myocardium. Generally speaking, it's believed that anything above 3 to 5 grams is considered reasonable contact to deliver a lesion. That's a major innovation that we can measure that because remember, when we're looking on Carto or on fluoro, the catheter, we just see it in the screen, and we don't really know for sure if we are touching the myocardium. And you can deliver energy in the blood pool and think you're doing an ablation, but in fact, you're just, heating the blood as it passes the tip of the catheter. So having the ability to measure how much force is being generated at the tip of the catheter is a very good indirect sign that you're making good tissue contact. All right, any questions about that? Let's move forward. Right, so someone is planning to, this is Dr. Sandeep Gautam, another Twitter EP is how I spend my free time. So this doctor takes a typical venogram, as we often do when we're going to put a pacemaker in or a defibrillator, and you see this. So what did the operator find? Let's go to Dr. Kaloff.
Hey, good morning, Dr. Pass.
Good morning.
So he's doing a venogram to see the course that the wires would take. Do you mean which vein is this? Or,
Yeah, like what did he find? Sandeep Gautam.
I think this is a left SVC.
Yes, that's right. That's exactly right. This is an LSVC, and where do you think it's going to?
Probably coronary sinus.
Yeah, it kind of looks that way. We don't have, unfortunately, he didn't give us the rest of the image, but presumably this is going down the coronary sinus. So this is something you don't really want to find out in the cath lab. And it's really one of the things that makes it, there's a lot of things about being a pediatric electrophysiologist that is harder than being an adult electrophysiologist. But one of the things that is easier is that we have really very detailed echo as a standard in pediatric cardiology. And so hopefully most of the time we would know pre-catheterization or pre-surgery if a patient had a persistent left superior vena cava. So what would you do about this? So let's say we're putting a pacemaker in. What would you think, what would be your strategy, Mohammed?
Um,
Could you put pacemaker leads through the coronary sinus into the heart?
no, no, I think you'd go through the other side.
Well, that's what I would do. I agree with you. I would probably go to the other side because I think it would be easier um, in some ways. But you can actually place leads through the coronary sinus, but it's a lot more challenging because the catheter is taking a very strange course. And to get the catheter or to get the lead to go into the right ventricle requires a lot of manipulation. And I think in general, leads are tolerated reasonably well in the coronary sinus, even with the risk for thrombosis and such. But I would say in general, my preference would be not to do that. Now, what about if you had a defibrillator? What would your thoughts be about? So for a pacemaker, I agree with you. I would probably go to the contralateral side just to make my life a little easier, although there's some issues with putting in leads from the patient's right side and all, but generally speaking, I think most would find that easier than manipulating through a coronary sinus vein. But what about if you were putting an ICD in? Would you do the same thing? Go to the other side? The answer might be yes. I don't know. Sorry.
I don't think so. I think it should be on the. Can you tunnel the leads with the defibrillator from?
Well, I mean, basically, what I'm trying to get at is, most defibrillator systems rely on the physical relationship of the device itself and the distal coil, which is in the right ventricle. And if you move the device to the contralateral side, to the patient's right side, then you will not have as much of the heart between the coil and the can. And remember that that's the shocking vector, particularly if somebody has a single coil system, which is what we prefer, which actually brings up another question. Why do we prefer a single coil to a dual coil lead? Probably nobody in our group here has seen either me or Barry put in an ICD lead that has two coils on it. Why, what is the benefit of two coils, and why do you think we don't use two coils or double coil leads very often?
I think if you have two, like just in case if one failed, maybe.
Now, the reason that you have two coils, so typically a dual coil lead has a coil at the end that's inside the heart, just like a single coil lead, but it has another coil that's more proximal that usually sits sort of in the innominate vein. And if you include both coils in the shocking vector with the device, you can sometimes achieve a lower defibrillation threshold. And so for somebody who you're concerned you'll have difficulty defibrillating, it used to be believed that having two coils would be potentially superior in terms of efficacy of a shock in defibrillating a patient. The reason that we've sort of moved away from that is twofold. First of all, um, the actual benefit of two coils is fairly minimal in many cases. The defibrillation thresholds have been shown in adults to be fairly similar between a single coil and a dual coil system. But the really important reason we don't like to have dual coils anymore is because they are very difficult to extract. The coil is thick and it has a tendency to fibrose more. And remember, I explained that the second coil is sitting either in the SVC innominate junction or in the innominate vein itself. And that's one of the areas that we're most concerned about tears during extractions. And so the last thing you would want is to put in a lead that has a higher chance of scarifying so aggressively to the vein that in the process of pulling it out, you could injure the vein or have an uncontrolled tear and bleed. So we don't really use dual coil leads very often anymore. They still are available, but we don't generally use it. So in this case, you could try to put it in from the right side and test your defibrillation threshold. I think a lot of electrophysiologists, though, might try to do this through the through the LSVC and getting it into the RV because of concerns that the vector of shocking would not be successful if the device were in the right shoulder. For sure, I would use a device that had the maximum energy if I was going to the right side. About 2 years ago, I had a patient who has dextrocardia and has a transvenous pacemaker that I placed from the patient's left chest. And I wanted to upgrade this patient to a dual chamber ICD because they had a form of double atlar right ventricle with a lot of ventricular ectopy and were sort of a setup for a VT or VF, and got a lot of opinions throughout the country about what the best option would be. And in the end, most people said to try doing it from the same side, from the patient's left side that the pacemaker was, and put in a new lead. So I was able to get another ICD lead into that young patient's right ventricle. And, normally you've noticed we almost never test defibrillation thresholds during implantation. And that is based on the fact that studies have shown that if the R wave is good size, if the pacing threshold and impedance are a good size, and if the patient has levocardia, the likelihood that a shock will be successful is very, very high. When I started my career, those data didn't exist, and so it was considered very routine and standard to test the device not once but twice, and make sure that there's a 10 joule safety margin between what you test and the maximal output of the device. And we still do testing in patients in whom we are very concerned for whatever reason. Maybe someone has a very large heart. Maybe a patient is a very large patient. We sometimes rarely do it, but it used to be dogma, basically religious belief that you had to do this testing in every single patient. Not only that, when I first started my career, it was thought to be routine to do it the day after as well. So every single patient in whom we placed an ICD, not only did we test them twice in the lab, but we tested them the following day. Interestingly, we had about a 10% failure rate on the second day. And I presented that abstract. And the reason, though, that it failed was usually because it wasn't enough energy. You have to remember that in the past, the maximal output on most defibrillators was 26 joules. And so 26 joules was not, or 26 or 28 joules, did not work in everybody. Today, most devices deliver between 35 and 40 joules. There were what they called at the time high output devices, which would put out 35 to 40 joules. But a lot of times, so sometimes we would have to take these patients back and replace their ICD, or we would place what's called a subcutaneous array, which would put a lot of, spread the energy over a wider path and often was efficacious at lowering defibrillation threshold. Today, another reason we don't test is that all devices today are quote unquote high energy. They don't really make the lower energy devices anymore. And I suspect this is due to an improvement in battery technology, miniaturization, as well as just a realization that there was a very real percentage of patients in whom the prior energy was inadequate to defibrillate certain rare patients. So in this case, if I had an ICD, I would probably either see if I could put in a subcutaneous device and avoid transvenous access entirely. But if I was set on putting in a transvenous system, if it was an ICD, I might try to put this in through the LSVC because of concerns about the shocking vector. Alternatively, one could go to the other side and do it, but you'd hate to do that and make an incision and then do a DFT and determine that it was ineffective, that it didn't work. So I think we would probably struggle and try to get it into the RV from the left side. It's not necessarily the right answer. There is not a right answer, but that's probably what I would do. Any questions about this?
I have a question, Dr. Pass. What's the
Sure.
risk of thrombosis in the coronary sinus if you go through it to place-wise? Because I just had a patient, an adult, who had an almost completely obstructed SVC from wires that were placed for a pacemaker. So, we can stand the SVC, but what would you do about the coronary sinus thrombus?
Well, it's an interesting question. Like, is there something bad about, blocking off the coronary sinus? Probably the answer is yes. Probably it's not good for you. And I don't really know this literature very well. I'm not sure if there is a very extensive literature. There probably is some. I think in general, it's tolerated okay. And I think what happens probably is patients develop collateral venous drainage from the coronaries through the heart to compensate, since it doesn't usually happen immediately. But it is a good question, and I don't actually know the full answer. But I think as a general rule, especially in an adult-sized patient, there should be flow around it in the CS, and probably collaterals develop over time to compensate for whatever blockage might be happening with it. When you're talking about the leads that are causing obstruction, we see, one of the things that comes up not infrequently with congenitals is the patient with a Senning or a mustard who has multiple leads in their SVC and has a stenosis.
He was a
because they-
mustard too.
Yeah, I see. So oftentimes mustard patients will have SVC or IVC obstruction naturally as a result of the operation. And then, by the way, they have a pacemaker lead in the middle of it. And that's always challenging because if there are already leads there, well, you can't easily stent it, because if you do, you could potentially damage the lead and jail it. So sometimes what'll happen is you'll have to do an extraction of the lead, followed by stenting of the vessel, followed by replacement of the lead. So it's a very large, involved procedure. And it's unfortunate, but as we've discussed in the past, virtually 100% of mustard and Senning patients ultimately need at least atrial pacing, and many of them even need defibrillators. So it's a very challenging problem in that patient group. So, all right, I think we're going to stop at this point. I hope everybody has a great day, and speak to you soon. See you soon. Thank you.
Thank you. Thank you.